Hello and welcome to Lisbon. My name is Nick West, the Chief Medical Officer of Shockwave Medical. We're here in Lisbon for CIRSE 2024, and I'm delighted to be joined by Dr. Raghuram Lakshminarayan from the Royal Infirmary in Hull, UK, and also Professor Andrew Holden from Auckland City Hospital in New Zealand, who's just presented the BTK II procedural outcome data that we're going to be discussing. Andrew, thanks for joining us.
Yeah, thanks very much, Nick.
So, let me put it to both of you. Now, you've both got slightly different perspectives. Of course, Andrew has seen the data and just presented it, and Raghu, you've just seen it for the first time.
That's right.
We're very excited about these data. It's the largest trial in the endovascular space that we have executed thus far. But maybe I can ask you both, what struck you about the patient population? How does it relate to other studies you've seen in this space?
Thank you, Andrew, for presenting the study. I mean, it was, I was very excited to look at the outcomes from this because BTK, as you know, is a very, very difficult area, difficult, long lesions. And the one thing that I liked about the cohort of patients was the fact that there were multi-center, prospective of very long lesions and Rutherford 3 to 5 with moderate and severe calcification. The thing that struck out to me from the patient population was also the fact that the diabetics were around 70%, which obviously is medial calcification along with the intimal calcification that we need to deal with and modify. And the fact that renal impairment was nearly 40%. So Andrew, you and the team have really got a really difficult cohort of patients that you ended treating with. So I was delighted to listen to it.
Yeah. Well, Nick, first of all, I fully agree with your comments, but I should first thank Shockwave and for the BTK investigators for the opportunity to present this data. And it was very exciting because, as you mentioned, it's far and away the largest data we have on IVL in the below-knee space. You know, I was lucky enough to be involved in the first in human, a very small study, and in the DISRUPT PAD observational study, which actually had quite a small cohort below the knee. So we really haven't had a big data set. To be involved in a trial, 250 patients, I think, makes us sit up and really take notice of this data. And as you mentioned, real-world lesion length up to 20 centimetres could be allowed. The lesion length of 77 millimetres is, a significant lesion length. Particularly, all of these had moderate to severe calcification. And I was thinking previously that really there isn't another trial that had this kind of a hostile cohort, moderate severe calcification in all of these patients, an intermediate kind of real-world lesion length, renal failure in 15% of the patients on dialysis, for goodness sake. This is really a challenging cohort of patients.
And I think that's what we set out to do, was try and encapsulate what people really experience when they're treating these patients, because I think in the same session we saw some interesting studies looking at the DCB use below the knee, also of various scaffolds, and of course by the nature of the design of those studies they may not necessarily truly reflect the kind of patients that you see. So moving on from that, so I think we've agreed it's, as you both said, it was a challenging patient cohort, a concentration of all of those factors that lead up to hostile lesion and patient environment. So maybe let's talk a bit about the outcomes and what you thought about those. So Andrew, you described the data. What struck you about the outcomes in particular and what we saw?
I think there were two things. I mean, we can divide them into efficacy and safety outcomes, can't we? So perhaps if I start in reverse order in the safety outcomes. But below the knee, the consequences of complications such as distal embolization are so severe that I think I would expect a higher adverse event rate. But the overall freedom from major adverse events was well below 5%. The dissection rate was well below 1%. If we have a look at things such as atherectomy by comparison and look at the potential risks, rupture embolization, they're far higher than what we saw with Shockwave. Efficacy really was defined, and we presented for the first time the intraprocedural clinical outcomes. How well did IVL work as a treatment, either standalone or with a second treatment for a final destination therapy? So just to remind everyone, this was done with crossing with a guide wire, pre-dilatation if necessary, delivery of the investigational device, the Shockwave IVL catheter, and then post-dilatation if necessary. We can talk a little bit about how much of that pre and post-dilatation perhaps to follow, but if we have a look at the outcome, that is the luminal gain, the primary endpoint was defined as technical success or treatment success being a residual stenosis of less than 50% diameter loss. And we could look at it both after shockwave and then final therapy. But the final therapy outcome was 99% of patients had a residual stenosis of less than 50% diameter loss. When we go back and think of the hostile nature of the kind of devices we saw, a significant percentage not only calcified but also CTOs we saw on around 30%. So really I think that primary outcome was very impressive.
And in fact, as you know, we also analysed those patients with a residual stenosis of less than 30%, and still 3/4 of patients actually achieved that. And as you've pointed out, the complication rate was very low. And in fact, before people begin to think it's all due to bailout stenting, of course, bailout stenting was also very, very low for a trial of this nature at around 5%.
Yes. Yeah, I was impressed with, again, I was surprised with below the knee. When we start doing real world lesions, we often are using provisional stents, of course, things like drug-eluting stents or TACs in 30 to 40% of the time. So this was really very pleasing to see such a low incidence of needing a scaffold as well. And as you say, 75% freedom from a residual stenosis of more than 30% was an incredible result.
Raghu, you saw the results for the first time. Clearly, we were privy to them beforehand. What struck you?
The fact that you didn't have to predilate in 70% roughly of patients was something that struck me, because you've selected these complex long lesions, so the trackability of the balloon, as was seen in all comers, it was a multi-center trial, so it was not in the capable hands of Andrew that was going down into the crural circulation. So I thought that struck me quite a bit. And also the fact that you didn't have to post-dilate in 70% of the patients, because like you say, we end up stenting almost about 30% of the patients, especially if it's extremely calcific. You can't get lumen gain without having to use a stent in 30% of the patients. But the fact that you use it as a single device and got 99%, if I remember right, of greater than 50% lumen gain, and like you said, more than 75% when you reduce it to 30%, was something that struck me quite a bit.
So it's interesting, isn't it? Because, as you said, the treatment paradigm currently without use of IVL may not actually encapsulate only 30% pre-dilatation and 30% post-dilatation. And Andrew, you hinted at you described both the safety and the efficacy. What do you think about the relationship of the relatively low frequency of pre-dil and post-dil with the safety outcomes?
Well, I think, it's really interesting. I must say that I'm still trying to think about those figures of 35% pre-dil and 35% post-dil. I think the pre-dilatation, like you, I was struck by that, and I think a lot of clinicians listening to this will be very reassured about that, because effectively it's very valid to think, well, hang on, I'm having to use traditional angioplasty to deliver IVL to get the benefit of IVL. Aren't I losing some of the opportunity of a very different form of angioplasty that IVL provides? So I think the fact that well over half of the patients, the first time lesions start to get manipulated is with shockwave. I think that's really important. And I think that probably does impact on safety, because I think if we're having to have a high percentage of traditional angioplasty with the known complications, then we may expect to see a higher complication rate. I think, the jury's still out with post-dilatation. It was very low. It's probably my personal preference, if I'm treating longer lesions, using overlapping shorter IVL balloons to post-dilate with a longer balloon in that sort of situation, but certainly with a very focal lesion, I'm not sure I'll get any gain out of post-dil. So I think it's really interesting to see the quality of results with only 35% having post-dilatation.
Yeah, because as you say, it's kind of the received wisdom that after calcium modification, you should, to ensure you've kind of consolidated the result, you've improved the compliance. Because of course, the pressure used in the shockwave balloons, the mean maximum pressure was only 5 atmospheres. With these kind of data, that show the efficacy and the safety, or confirm the safety and efficacy, if you like, in a truly real-world BTK population, that this will enable people not only to have confidence in using Shockwave, but also transferring those results to the E8 catheter, which is going to be a device that more endovascular interventions are keen on, rather than the slightly shorter balloon platforms we've had today. So gentlemen, thank you both very much indeed for your time. Thanks for all the discussion, and cheerio to everyone from Lisbon.